We're about to begin a surgical procedure demonstrating cataract surgery in a very small pupil. You just saw a caliper make a mark of 3.5 millimeters on the corneal limbus for the purpose of creating a corneal groove. A Thornton ring is used to stabilize the eye, and then using a diamond blade set at 0.5 millimeters depth, the incision is made between the two marks of 3.5 millimeters. A paracentesis is then performed. You'll see a previously made laser iridotomy because of narrow angle. This patient had recurrent iritis and had essentially almost 360 degrees synechia, or at least 270 degrees, with a very small myotic pear-shaped pupil. 1% preservative-free xylocaine is injected through the paracentesis in order to produce adequate anesthesia of the eye. The only other medications was topical Marcaine 0.75%, several doses prior to the surgery, as well as topical antibiotics 3 days before. In this case, Zymar was used, as was Acular, 4 times a day, 3 days prior. Cyclogel was used on the morning of the surgery upon awakening, and then 1 hour before leaving for the surgical center. The goal of this procedure is to enlarge the pupil adequately in order to produce the, in order to perform a cataract and implant surgery. You will see this procedure. You will see ultimately use of Vision Blue. This procedure will ultimately be performed on the Alcon Infinity system. We're going to use a Duovisc as it's easy to remove. The Duovisc is being used to perform the Synechialyis, and once the Synechialyis is performed, a cyclodialysis spatula will be used to break as much of the adhesions as possible. Some of the adhesions which are in the temporal quadrant are more difficult, and ultimately they'll be broken at a later point in time in the procedures you'll see. Viscoat is placed on the corneal surface, and then balanced saline. This is used to keep the corneal surface moistened throughout the procedure. It works extremely well for this purpose. In order to get adequate exposure of, or at least contact of the Vision Blue dye to the anterior capsule, the cannula that is used is bent straight. We use a 30 gauge cannula, so it's bent straight such that the Vision Blue can be injected underneath the iris. This will be seen later. We're now using a 3.5 millimeter keratome to make a beveled clear corneal incision. Cyclodialysis spatula is used in the paracentesis in order to stabilize the wound. Viscoat was placed in the in this case, Duovisc was placed in the anterior chamber to have a more firm eye. Some surgeons prefer to have no viscoelastic in the anterior chamber. Now that Synechialyis has been performed, in order for the Vision Blue to be to adequately contact the epithelium of the lens, the Provisc by Alcon viscoelastic is removed with the irrigating aspirin handpiece. You'll notice we use a soft tip on this, and this does a very good job. Viscoat could also be used. It's a little bit more difficult to remove. If you do not remove the viscoelastic, Vision Blue will not effectively stain the anterior capsule. And the purpose of staining the anterior capsule is generally speaking, in these cases, you have a small pupil, and you want to have a very accurate curvilinear anterior capsulorhexis, and not be concerned about its size. And the visualization of the anterior capsule using the Vision Blue greatly enhances your at least comfort, as well as reliability and consistency of performing the anterior capsulorhexis. An air bubble is then placed in the anterior chamber. I then use a viscoat to just plug the wound. Not sure that's truly necessary, but once that's done, then the Vision Blue on this straight cannula that has been bent will then be injected first on the anterior surface of the lens and then underneath the iris. In this case, the pupil diameter was approximately 2, if not no greater than 3 millimeters. So if we only injected the Vision Blue into the anterior chamber, then only the central 2 millimeters would be exposed, and once we dilate the pupil, would have very little markings or enhancement of the anterior capsule for the capsulorhexis. Thus, the purpose of injecting the Vision Blue underneath the surface of the iris. Here comes the Vision Blue. You can see it. This is an outstanding product. Perhaps it's a little more expensive. I'd like to see it. It is far superior to the green dyes that we had to use prior to the availability of Vision Blue. The assistant irrigates the dye from the cul-de-sac. This is not truly that necessary, just makes for prettier surgery. The dye really immediately is taken and taken up and stained by the epithelium of the lens capsule rather quickly, and it can be removed. In this case, I use because we opened up the anterior chamber, simply use viscoat to, we start in the nasal quadrant, and then the viscoat is injected, and ultimately as the viscoat fills the anterior chamber, there's complete removal of the Vision Blue. Now, a 30 gauge needle is bent at 90 degrees, and then near the hub we bend it approximately 120 degrees, and this very inexpensive capsulotomy needle is then used to make the initial rent in the anterior capsule. Now, before we can do all that, a Beehler iris forceps iris dilator is being used. You'll see 3 prongs coming out of the this cylindrical steel tube. There's the 3 prongs coming out. It captures the iris distally, and then there is in a sense, a hook that is captured onto the temporal portion of the iris, and as you retract toward yourself, you also push the 3 prongs forward, and you can see the marked dilation of the pupil that is achieved. Now, the Beehler really works best in a small pupil such as this, 2 to 3 millimeters. When you get into larger pupils such as 5 millimeters, it's a little bit more difficult, and in those circumstances, I simply use a Repazzo haptic scissors is used to cut the haptics of an implant, and then Vaness scissors to make multiple sphincterotomies. Generally, the sphincterotomies are performed at the 3 and 9 meridians, as well as the 6 o'clock meridian, and then also at the oblique angles as well. The inferior cuts are made with the Vaness, and the more superior made with the Rapazzo. And now you can see how large the pupil is, and by injecting viscoelastic, the pupil is approximately 7, if not 8 millimeters in diameter. There's a slight amount of bleeding at the sphincter. Injection of 1 to 1,000 preservative-free epinephrine, which makes it a 1 to 4,000 concentration, is then performed intercamerally in the anterior chamber, and this facilitates the constriction of the blood vessels and elimination of any bleeding. Again, you'll see Viscoat being placed on the corneal surface with balanced saline to facilitate long-standing clarity of the corneal surface. The rent in the anterior capsule is performed with a 30 gauge needle, and now using a Utrata forceps, some modified Utrata, we have beautiful visualization of the anterior capsule, and it's the anterior capsulorhexis is not performed in its usual manner without the risk of tearing the capsule peripherally. This is more common when one does not see the anterior capsule. In the case that the capsule would tend to get away from one and move more peripherally, simply adding more Viscoat or a dispersive viscoelastic in the anterior chamber will facilitate and reduce that likelihood. Once achieving this, this method allows us to achieve a very well placed and central anterior capsulorhexis. Balanced saline is now used to cause separation of the lens nucleus from the lens capsule. So hydrodissection of the lens nucleus is and cortical material is done routinely, and once this is performed, this will facilitate the rotation of the lens nucleus, which is critical in order to prevent zonular dialysis. It's not unusual that at times I will inject 3, if not 6 cc's of solution, if necessary, for adequate rotation. Sometimes I'll even use a viscoelastic and inject it, such as Viscoat, especially in the nasal, underneath the anterior capsule nasally. And now at this point in time, we begin the phacoemulsification because we have adequate exposure, which is critical, obviously, in cataract surgery. So we've completely resolved the issue of the small pupil by doing the Synechialyis and ultimately dilating the pupil adequately with the Beehler Forceps. And using the Vision Blue, we have effectively performed an anterior capsulorhexis, which is large, and now phacoemulsification performed. There's many techniques. My technique is simply to perform a central vertical groove and then subsequently rotate the lens 90 degrees. Again, as stated before, rotation is critical to prevent zonular dialysis, so hydrodissection of the lens nucleus is a critical component. Once the vertical groove is performed, then we rotate the lens nucleus. In this case, it does rotate. In the unlikelihood that it doesn't rotate, Viscoat is again injected, and I'll use a cyclodialysis and a Sinskey hook to facilitate rotation. In this case, it rotated nicely. So the lens is rotated 90 degrees, and the second groove is then performed, and then we rotate it a third and fourth time in order that we effectively perform, in a sense, a Maltese cross, or a groove similar to that seen in a Phillips head screw. It's critical to be reasonably deep, but not so deep that you're going to be concerned that you're going to perforate the posterior capsular bag. In a case like this, we use a nuclear cracker, and so to enhance that, I am simply again adding Viscoat. You'll see that a great deal of Viscoat is being used in this case, and it not only facilitates exposure and maintains space, but is also healthy for the corneal endothelium. And now the nucleus cracker is placed into the peripheral vertical groove, and as it spreads, it creates a very nice an equal pressure against both halves of the nucleus, and nicely crack the lens deeply. You want to overly spread this thing because you can actually cause a rupture in the capsule. You then rotate the lens, which is done cyclodialysis spatula 90 degrees, and the cracking is then performed 4 times in each quadrant. Under certain circumstances, the cracking is not through and through, and this may require one to use again a cyclodialysis spatula and a Sinskey hook, or simply use the tapered end of the phacoemulsification tip and a cyclodialysis spatula, or some type of a chopper, or whatever one feels most comfortable with, in order to facilitate complete separation of the 4 quadrants. And then phacoemulsification is then performed. We're in the quadrant removal. The suction is at probably 500 millimeters of mercury, and we have high pressure to basically pull the lens nucleus into the phacoemulsification tip. If we don't find the right quadrant to do this, we may rotate the lens until we find the right quadrant. Once we get the first quadrant up, things seem to separate much easier. This specific phacoemulsification does not have Ozel technology. In the case with Ozel technology, generally I will try to get the first quadrant up using non-Ozel technology, and then once that first nucleus becomes more central, Ozel technology and high suction will easily phacoemulsify, very nicely phacoemulsify the lens nuclear fragments. But this Alcon Infinity without Ozel technology is doing a very nice job. I believe the case basically becomes most routine simply because of positioning. Of having a dilated pupil with a nice capsulorhexis and a stable anterior chamber really pretty much turns this difficult case into a rather routine case, and gives the surgeon a great deal of satisfaction knowing that the complexity of the case is now turned routine, and we can proceed with cataract surgery and ultimately lens implant surgery much like we would under normal circumstances. I think the key, however, is that one should try to perform the surgery, this was certainly by no means an early cataract, but you certainly don't want to be working on a 4+ nuclear sclerotic cataract on a grade 4. I mean, you'd like to operate at grade 2 or grade 3, which is going to make life a lot easier for you as a surgeon, and ultimately the result a lot better for the patient involved. Once the phacoemulsification has been performed, then we use the soft silicone tip, which makes the chance of sucking the posterior capsule, even if it does inadvertently, much less likely of rupture during irrigation and aspiration with this silicone tip. We've been using this for years, and the rate of posterior capsule rupture is probably in the neighborhood of 1 in 500 to 1 in 1,000. Although I don't have, that's more anecdotal than actually scientifically proven. But it's very, very, very unusual that we would have a rupture of the capsule during this phase. It was not uncommon with the non-silicone tip that the posterior capsule might inadvertently be sucked into the steel probe, and then an inadvertent tear in the posterior capsule, which is most frustrating, as you know, to the surgeon who's worked so hard to get to this point, and then so close to victory with only the agony of defeat of posterior capsule rupture, and then ultimately potentially a change in the philosophy of the type of lens that one's going to insert, plus the risks involved in potential vitreous loss and or vitreoretinal complications. With very generous hydrodissection prior, this removal of residual cortex becomes a rather straightforward process. And once that's been performed, then we simply are going to inject the Provisc, which is the second component of the Duovisc of the Alcon surgical viscoelastic, and then insert the implant of choice. Our implant of choice is the Alcon SN60WF. They now have a WS, which has an automatic loading cartridge, in a sense. I tend to be one who prefers to, in a sense, twist the lens in, and the newer WS implant is a plunger technique. Word on plungers in general, and it's been written up in numerous journals about specifically when using injections through a paracentesis on a TB syringe or a 3C syringe. If you're using a non-luer lock and there is some resistance and one uses too much force, you literally could create a dart, which has been demonstrated to not only cause laceration of the cornea but also perforate the posterior pole as well. So we're a luer lock only OR or non-luer lock free OR. So all our syringes have luer locks to prevent such a occurrence from happening, which really there's no reason for such now that we are aware of that potentiality. The implant is injected and it folds nicely, and as you can see, it's nicely into the posterior capsular bag. In this case, I really probably did not need a corneal suture. You'll see a corneal suture is being placed as we're doing the surgery on a Thursday, and as I'm in the hospital on a half a day on Friday, and not in the office on Saturday for religious reasons. It's just safer to put a suture in. Generally do not, but and generally I don't operate on Thursday, but in this case There's no place for an ego, and so we simply place a suture, and it can obviously be easily removed post-operatively, so that we have no surgically induced astigmatism. If one doesn't overtie it, it's really not an issue regardless. Oftentimes, in actuality, these patients have against the rule astigmatism, as this patient did, and so, or actually this patient had, with the rule astigmatism, and so ultimately by using the suture we can kind of reduce that. It's important to have square knots, and so otherwise it will slip and get loosened or be of no value. You're seeing that done, and then we simply use the paracentesis knife to cut the suture close to the knot, and then generally we'll bury it with a jeweler's forceps. You'll see in this situation that the jeweler's forceps had difficulty with, and I should have just simply used a suture tying forceps in order to bury the knot. Now the issue then becomes, what should you do with the pupil? And it's debatable. You could do nothing, or you could add myocol, you could add myostat, you could add pilocarpine. In this case, we simply added myocol. Myostat I do like, but it does tend to have a tendency to cause the cholinergic effect. We can reduce that with several antiemetics that are used and is given by the anesthesiologist to prevent the nausea post these cholinergic drugs. At the end of the procedure, simply put Viscoat on the surface. Again, it's a good lubricant post-operatively. They tend to be a little dry. Antibiotic of choice, generally a fluoroquinolone is instilled. Patient is given a beta blocker unless there's some cardiac issue, and then just a shield over the eye, or if they prefer, they could wear sunglasses. I'm showing you that we're going to place myocol into the eye. It's on a filtered cannula, just to bring that pupil down a bit, so we don't, hopefully won't have an atonic pupil. Actually, if we do have an atonic pupil, it's already been caused, and myocol have very little effect on it. And we're simply testing the wound here. Usually I'll use a 4x4 to kind of, bluntly dry the area, and then use a 4x4 to make sure that there's no evidence of wound leakage. Sometimes we'll wait a minute, much like Lasik, to make sure we have good adherence and have the endothelial pump close the wound when there's no suture. But in this case, we have a suture, and again, simply placing viscoelastic, and that's going to basically be the end of the procedure. I thank you so very much.